Yeah, welcome everyone to the Global Sepsis Lecture. It has been a while, almost 1.5 months since the last lecture, and this lecture is provided by our network, which is a network about sepsis research. It's called STARS, and STARS means Sub-Saharan African Consortium for the Advancements and Innovative Research and Care in Sepsis. So I'm Hélène David. I'm an intensivist and anesthesiologist from Charité, which is one of the partner university and hospital working in this network. But we have seven partner country and hospital around Sub-Saharan Africa. One of them is Ethiopia. And we are two partner hospitals in Germany. So this is about us, and this lecture is about improving sepsis knowledge, but also a platform for exchange about sepsis in the sub-Saharan context. So today we are really happy to welcome our expert from St. Paul's Millennium Hospital, which is one of the biggest hospital and university teaching hospital from Ethiopia in Addis Abeba. And this hospital correct me, Dr. Nura, has the biggest, one of the biggest ICU of Ethiopia. Dr. Nura is the head of the whole critical care of this hospital, and she's especially specialized in adult ICU. She's a senior specialist and consultant in anesthesiology and intensive care. Today, Dr. Nura is going to talk about the use of antimicrobials on the ICU for sepsis care. And we think this is a quite relevant topic today. So Dr. Nura is going to give us insight to when should we use antimicrobials, when to start it, how to start it, which one should we use, so give you some practical insights. So we are really happy to have you, Dr. Nura.
Thank you, Dr. Helen, for your generous introduction. So I'm an intensivist as today. I'm not infectious disease specialist or microbiologist. I want to present sepsis antimicrobial management from intensivist's point of view, and then what are the main challenges and controversies we actually get in our day-to-day practice when we manage sepsis. That's it, what I'm going to present. So topic is as described. So I don't have any financial conflict of interest to disclose. So I will start with some questions. So on this presentation, we need to see what is the appropriate time to initiate antibiotics in sepsis and septic shock, things to consider during empiric coverage of antibiotics, and what physiologic, pharmacokinetics, pharmacodynamics changes are considered in these patients, and antibiotics dose adjustment in AKI, and when should we consider double antimicrobial coverage. So the answer for these questions, so I'll project this slide at the end of the presentation, and this is my outline of the presentation, and then I will deep dive into that immediately. So as an introduction, sepsis is known since Hippocrates' time. It's a medical emergency. And especially if you've seen this new sepsis, surviving sepsis guideline 2025, it says it doesn't suggest any tool or any of the SOFA or QSOFA or any one of it as a single tool. It rather says like clinical suspicion, rigorous diagnostic measures, and aggressive initiation of appropriate antimicrobial therapy, comprehensive supportive care, and then measures aimed at reversing the predisposing causes. These are the cornerstones of successful management. So mind you, in this series, initiation of aggressive appropriate antibiotics is also here. So, okay. So this is surviving sepsis guideline. As you know, it's a global guideline to be implemented by everyone. And then it showed there was this 7.5, around like 7.5 years analysis. So so the analysis demonstrates the increased compliance with sepsis performance bundles was associated with 25 relative risk reduction in mortality rate. That's a very important thing to note, but full implementation of this surviving sepsis guideline in Sub-Saharan Africa or lower middle income countries is very much challenging. So there is a gap between guideline recommendation and a real practical application. Yes. So, as you know, there is also another well-known study which showed every hour counts in septic shock with regard to initiation of antibiotics. It says around 8% absolute decrease in survival with delay in 1 hour antibiotic initiation. Next one. So this is very important to note, especially with resource limitations like in our case. But this strongest evidence was, I think it's a Seymour study for early initiation, 1 hour, which is very much associated with decrement in mortality for patients with septic shock. But for with sepsis, there is no much of a difference while the time of initiation is less than 5 hours. Again, here I want to note a very practical point. If we're like counting hours, what is a T0? When is this T0 started? So it differs in studies. I have a next slide. So is the time zero is pre-hospital EMS contact or emergency department triage, ED physician contact? T0s are different in different studies. Next slide, please. Yes, so many of the studies use from EMS contact, but is it, as you know, another practical point to mention, noting that our patients come delayed after the symptoms started, and then there is a problem in the referral system, then in the ED triage, and then to come to the appropriate place where they really get a treatment. So this is also one of the things to say. So to compile with our surviving sepsis guideline on the next slide. So these are most of the studies, and then how did they document the T0s? You can look at it. I'll share the slides. Okay, next slide, please. So we need to have a balancing act. So on one hand, we have timely effective empiric therapy, which is associated with improved survival and decreased morbidity mortality. And on the other hand, we need to have also compiled with principles of antibiotic stewardship or rational use of antibiotics, as it's associated with decreased antimicrobial resistance, and also it will decrease the risk of C. difficile infections. Next slide. Can you go for next slide? Because I cannot make it.
Yeah, I'm trying. It's not working. Wait.
So that's where we need to get a fine balance, because if we start irrational antibiotic use, it also counts for later increment on our antimicrobial resistance for later use. So assumptions of efficacy of timely antibiotics, there is a correct diagnosis, a plausible syndromic and pathogen-specific differential diagnosis, appropriate antibiotic choice. So we need to have the urgency to go broad and to go hard, but still rational. So we have to balance these acts. Again, next slide. Yeah. Yes, so we say appropriate antibiotics, it has a prospective and retrospective definition. So when we say prospective, antimicrobial coverage that provides adequate in vitro activity against all likely pathogens at the clinical infection site of interest. And this is really applicable when we use or administer empirically, or when there is culture negative sepsis is there. But when we say retrospective, it's applicable after culture positivity when antimicrobial coverage is indicated in vitro activity against the causative organism. Next slide. So this is what we say appropriate. Another balancing act on this is to avoid unnecessary antibiotics and to use of appropriate initial antibiotic. So next slide, I need to go fast on this one because it's going to be repetition. So because if we like make it inadequate, if our antibiotics are inadequate, it's associated with 20 to 40% higher odds of death. With adequate therapy, there is a risk of over treatment when we are irrational. So, and it's also associated with 20% increase in odds of death. So both has risks, as we can see, because antibiotics are associated with many organ system complications, which I will come to next. Next slide. Yes. So 26% increase C. difficile infection. Yeah. So more acute kidney injury. So broad spectrum antibiotics, they disrupt gut microbiome and increasingly recognized modulator of the immune system. So this cumulative also, as a practice, they will add antibiotic resistance on the later outcomes of our management. Okay, next one. So finally, there is a fear rather than a knowledge deficit. It drives antibiotic use. So next one, what is fear? Next slide. So this is very important. How can we not be previous slide? Sorry. You. Yes, but how can we not be scared? How can we not fear? As you know, I took two Ethiopian studies as a representative of African study. First one is a Black Line, the Gwambassa Hospital study. I mean, it's a tertiary care. And on this study, there were around So around the MDR rate for this study was 81%, with carbapenem resistance 58%. That's the biggest tertiary hospital in Ethiopia. And another study in Ethiopia which showed septic shock mortality rate of 67%. So knowing this data, both on the mortality of septic shock and then prevalence of antimicrobial resistance around 81%, carbapenem 58%, very scary. So with this, how can we not be scared? That's how we articulate. So the next one. So what should be our course then? As I said, another balancing act. So be fast, be broad, be aggressive, but we shouldn't not be mechanical. We should be cerebral. That means what we think everything case by case. But the most rational way to go about it would be to have local data, which is antibiograms, surveillance, and research. So in the next slide, I have this rational ways of like to start broad, hard, and so broad gram-negative coverage plus pseudomonas would be like piperacillin tazobactam or cefepime with metronidazole. It depends on the focus of infection we are entertaining, or meropenem. And MRSA coverage, MRSA coverage when indicated. So these indications, as you know from different literatures, documented colonization by methicillin resistance staph aureus, recent hospitalization or IV antibiotic recent use, recent surgery, hemodialysis, IV indwelling central venous catheter, or intravenous drug use. These are the risk factors which may signify MRSA coverage, because risk factors for MRSA are one of this. Otherwise, we need to stick on to our gram negatives. Thank you. Next slide. So for MRSA coverage, good antibiotics will be vancomycin, or we can choose between vancomycin and linezolid. First thing is first, always. So culture comes first. Like in an ideal scenario, if we have the time for septic shock, for example, to start antibiotics like within 1 hour, we may send culture and then start within 1 hour. Or for sepsis, we have this more time luxury, around 3 to 5 hours. We can send culture and start antibiotics. So that's first thing. That should be the first thing. And there are several reasons for negative culture. As you know, they used to say like the commonest finding in the culture is negative growth or no growth is a primary growth in the culture is no growth. So there are many reasons for negative culture growth, like cost factors, like the bug factors, treatment factors, and therapeutic factors. So the timing and the quality, the logistics are very important, but by any means, all attempts should be made at microbiological confirmation of an infectious etiology. Next slide. Yeah, thank you. So we should collect the right sample the right way at the right time to be stored and transported in the right medium. So how many sets of blood culture should be sent in sepsis shock? How should you send samples for cultures? And do you know the most important determinant of positive yield from the blood culture? These are some practical questions which are raised always, which I have some of the things to be considered in the next slide. Yes, thank you. So first, volume is very important. And the other, we need to disinfect our venipuncture site with chlorhexidine in adult patients, especially not in infants less than 2 months. Draw blood for culture before initiating antibiotic therapy because it also affects our culture results. Catheter drawn blood cultures, they have a high risk of contamination. False positives high, so they're not recommended these days. And even do not meet catheter tips for culture. Never refrigerate. Use a 2 to 3 bottle blood cultures for adults. So these are some of the guides. Please, next slide. Yes. And next slide again. So blood culture bottles not available. The patient cannot afford blood culture. These are the main things which we encounter in our setup, so that we don't know the target. Like we have to cover all possible microorganisms with antimicrobials at hand we have. So we don't have one single target. We have many targets in these scenarios. But I would say the studies show blood culture bottle not available in patient cannot afford, even in our local studies in Ethiopia. These are the common reasons why not sending for culture results. So we need to go, we need to look for a broader. And the other first thing is location. Source control is very important. I will summarize it within 4Ds. So drainage, if there is abscess, drain the abscess. Debridement, an infected wound or any infected site or a surgical site, it needs to be debrided. Device removal is our in central lines infected, or if you like consider sclerosis, central line associated bloodstream infection, as per recommendation, they need to be removed. And definitive measures like surgical management of our infectious sources may not be straightforward as it seems, but known or suspected locations for our sepsis origin, needs to be managed with source control. Okay, this also recommendations on surviving sepsis. I have put all the evidences for what I'm saying downward so that you can look at it. Okay, next slide. Thank you. So other thing in sepsis with their antibiotics is pharmacokinetics and then pharmacodynamics. So as you know, in sepsis, some physiologic changes and PKPD changes are there, like increased cardiac output, vasodilatation, decreased in albumin, some of the things to consider. And on the next slide, I will show you how the different kind of drugs yes. So can you go the next? I think it's next one, please. Yes. So we broadly classify our antibiotics as hydrophilic and lipophilic antibiotics. So pharmacokinetics changes in critically ill patients. So in hydrophilics, there is an increase in volume of distribution, increase or decrease in renal clearance dependent on the renal function. If there is septic in, there will be decreased clearance of hydrophilic antibiotics, and there is decreased intestinal penetration. And lipophilic antibiotics, volume of distribution may not be that or equivalent to as that of non-septic state, but there is an increase in renal clearance and then equivocal kind of intestinal penetration. So some of our hydrophilic antibiotics are aminoglycosides, most beta-lactams, carbapenems, and linezolid, but our lipophilics include fluoroquinolones, macrolides, and the others. Okay, next slide. Yes, thank you. So yes, this is about something. So these are the things to how can we like make our like antibiotics more potent in sepsis, like effects of dose increment, prolonged infusions on beta lactam exposure. I don't know if you can see this slide clearly. The first one shows their dose increment and then infusion rate. Let me take you to this last slide here. As you can see, there is a 50% increment by antibiotic concentration with increment in dosage, and then in prolonged infusions of beta-lactam antibiotics. So these are some of the adjustments you can make. Like, for example, I would take good example for meropenem. We may give it like 40 minutes administration in a normal scenario, but if you want to make an infusion, prolonged infusion, you can give it in a 3 or 4 hours. So this administration is known to be, I will like show you the evidence in the next slide. So combination of these adjustments may increase the antibiotic. So this is the evidence, prolonged versus intermittent infusion of beta-lactam antibiotics in adults with septic or septic shock. So based on this, the findings was it's a systematic review and Bayesian meta-analysis of 18 randomized controlled trials, and there was a 99.1 posterior probability that prolonged infusions were associated with lower 90-day mortality compared with intermittent infusions with risk ratio of 86%. So to restate this one, the risk ratio 0.86, or there is a 14% reduction in mortality, and it's a Bayesian model which also incorporates the evidences and also the pre-assumptions which infusion decreases mortality. So it's with 99.1% posterior probability means this is high likely that's efficient or this finding is true. So that's one of the things which needs to be notified. So with beta-lactam antibiotics, prolonged infusion is one of the things to consider in our antibiotic practice. Thank you. Next slide. Yes, Anna, next slide. Similar. And the other thing is in the kidneys. The other thing we fear is AKI. So there may be mostly septic ATN or AKI in sepsis, as you know. So one of the things is antibiotic adjustment because of fear of not further injuring the kidney. And as of the papers I have found, that's one of them. Clinicians do mistake in this area. So the hypothesis is renal impairment in sepsis is acute rather than chronic. Of course, CKD patients can come with sepsis, but the usual scenario here is it's an acute rather than a chronic injury. In clinically meaningful proportion of patients admitted with infectious diseases, and that impairment usually resolves within 48 hours in a substantial portion of cases. So it's one thing, it's transient. Overall rate of AKI on admission is around 1 in 5, which is near 20%, and AKI resolved in like more than half within 48 hours. So one thing, as I said, it's not as a CKD kind of or a chronic kidney disease. So it is transient, one thing, and the other one, most of the things to adjust in AKI, it may not be applicable as that of drug adjustment or antibiotic adjustment in CKD patients because transient and also dynamic. Okay, next slide, please. Yeah. So a significant reason for poor outcomes in sepsis may be underdosing. So I will take this best practice recommendation from infectious disease specialists and from guidelines. So for renally cleared drugs and for drugs with wide therapeutic window, which is most of our beta-lactam antibiotics, please offer full dose first 48 hours of safety of sepsis and septic shock. So your first 48 hours of dosing should not be renal adjusted or adjusted based on GFR. Rather, give full dose as that of otherwise okay or normal renal function patients. And for time-dependent drugs, when dose adjusting, reduce dose over reducing frequency. So because time-dependent drugs, they depend on frequency of drug administration rather than their dose. But concentration-dependent drugs, like a good example would be fluoroquinolones, it's better to adjust the dosing frequency than so if it was like 1 gram BID kind of dosing, it's better to make it 1 gram daily than like 500 gram BID. This is for concentration dependent antibiotics. Time dependent antibiotics, you keep the timing, but you can decrease. If it was 1 gram, you'll make it 500. And if it was 3 times per day, you can adjust it as like BID or once daily based on their creatinine clearance, or sorry, for based on their glomerular filtration rate after the 48 hours of dosing. The other very important thing here is that we do practice for patients who have indication for MRSA coverage. We do give vancomycin, and then last time we were asking here how many of our clinicians, physicians do practice loading of vancomycin, and then it was surprisingly very few. So one thing, we need to give this vancomycin, which has a renal injury effect. As you know, it should be used rationally for those who have the risk factors for MRSA coverage only. And the next thing, if you like commit giving beta-lactam, vancomycin, you need to give a loading dose of vancomycin, irrespective of patient's creatinine or renal function. Thank you. Next slide. Yes. So the next question is double coverage. Do we really need dual gram-negative antibiotics? Is it really evidence-based so that we cover, like we combine meropenem with ciprofloxacin or meropenem with aminoglycosides or other gram-negative coverage? Evidence for synergy of 2 gram-negative antibiotics is honestly sparse and conflicting in vivo synergy. Sorry. Okay, so in vivo synergy doesn't directly translate to clinical efficacy. So one, evidence is scarce. It's for the spectrum. Just in case one agonist is not active, there is no benefit of double coverage if you have a confirmed pathogen. So next slide. Yes. So this is the greatest benefit. I just want to imply, like I mentioned, most of the trials and the studies, but the whole summary of it is the greatest benefit of combination of antibiotic therapy or double gram-negative coverage for that matter likely stems from increased likelihood of choosing an effective agent during empiric therapy rather than exploitation in vitro synergy or prevention of resistance during the definitive treatment. For example, the good example I want to give is there is this double gram-negative or double pseudomonal coverage assumption, and there is a tendency to use. Good example will be meropenem with ciprofloxacin. As you know, antibiotic coverage of meropenem is very broad and very strong. So we are most likely succeeding with meropenem than like combining meropenem with ciprofloxacin. Next slide, please. But however, there are some places. So okay, so the next question will be, if at all there is a need to combine two antibiotics, which antibiotics shall we combine, and then how? So beta-lactams, as you know, they're the safest antibiotics we have. And then if you choose one beta-lactam, shall you combine it with two beta-lactam antibiotics, or beta-lactams plus aminoglycosides, or beta-lactam plus fluoroquinolones? These are the three type of combinations we are using. Surprisingly, evidences show, next slide, Helen, sorry. Combination of beta-lactam plus aminoglycosides versus beta-lactam plus fluoroquinolone empiric therapy in serious nosocomial infections due to gram-negative bacilli. So surprisingly, the effects show so on this, a total of 129 patients receiving aminoglycosides like 83, and then 46 receiving fluoroquinolones. The number discrepancy is there, as you can see, but 7-day clinical cure rates were 74% and 72% for fluoroquinolone in aminoglycoside group with p-value insignificant. There was no significant difference in the odds of clinical cure with these two combination with either of some. And then there is also no significant difference in 28-day mortality. Next slide. Yes, so this is what I was mentioning. Surprisingly, the commonest growth in most of the Ethiopian studies was E. coli from culture positive findings. So E. coli is found to be 90% ciprofloxacin resistance, followed by Klebsiella, the next common growth, and Klebsiella is even 96% resistance for cipro. And double pseudomonal coverage, as you can see, Pseudomonas is 40% resistance for ciprofloxacin. Amikacin is one of the aminoglycosides we use as a combination therapy. Here, the resistance rate rather seems better. It's 23%. Is this all in vitro resistance, of course? So this is a Turku specialized hospital study. Next slide. So how should our practice be, and what are the key messages on these combination therapies? So we need a local antibiogram. So based on the previous data I showed you, it seems meaningless to combine, especially if you are using meropenem with either of the two, but more importantly with ciprofloxacin, considering double antimicrobial coverage or double gram-negative coverage. Most opt for fluoroquinolone, as you know, it's because of safety profile, especially with nephrotoxicity associated with aminoglycoside use. And most gram-negative resistance in a hospital is plasmid mutated, which means resistant mutation for different antibiotics are extended. There is a possibility of cross resistance as well. So, and then if gram-negative isolate is resistant to broad-spectrum beta-lactam, it's a study shown that its likelihood of sensitivity for fluoroquinolone is very minimal, around 30%. And there is, I would say again, aminoglycosides are strong antibiotics. They demonstrate some synergy with beta-lactam for gram-negative bacteria in vivo and in vitro. So clinical implication, however, is unclear. So the whole message here is that as much as possible, culture-based single antibiotics, or empirically, even when you use, try to make a more potent one rather than considering synergy and then combining two antibiotics. Okay, next slide. And the next thing, so now we choose our antibiotics. Next topic will be descalation. So empiric versus targeted descalation. So descalation, the message is it should be rational, like initial choice based on clinical progress of the patient, investigation results, and then if we possibly able to do a microbiology or a culture result serially, it better be rational than empiric descalation. Thank you. Next slide. Okay, the next slide. Sorry. Next slide. So these are the evidences. The next thing after de-escalation to consider is how about the duration? So that answers our question, most of our questions, I hope. So some give 14 days or beyond, even 21 days, and then 5 to 7 days. So many studies which I was trying to see doesn't show any benefit of like giving longer term antibiotics like 10 to 14 days versus short term like 5 to 7 days course of antibiotics. In fact, there is a very recent study which is called a balance trial, which has also many so please next slide, I will like demonstrate a balance trial in the next slide. Okay, so even surviving sepsis suggests against using longer term antibiotics because the evidence show so. So the big evidence we have recently is the balance trial. Next slide. Yes, this is a balanced trial. It's an open-label, randomized, control, non-inferiority study. So the initial question undermined was like short-term antibiotics, like 5 to 7 days, is non-inferior, 7-day group, non-inferior than longer term, which is 14-day antibiotic use. To the results of this study, it was a 2024 study, I guess. An open label randomized control trial. So the result of this one, and also it includes many participants from different countries. You can look at it, a balanced trial over on duration of antibiotic use. It's found in New England Journal of Medicine. So the result of this study was antibiotic treatment for 7 days was non-inferior to treatment 14 days with respect to days from any cause within 90 days. But as you know, longer term antibiotics has more consequences, but it was non-inferior. The shorter term, it is non-inferior with regard to even 90-day mortality, but giving unnecessarily longer time, as you know, resistance increases, side effects increase, and also cost is also very important. Most of the potent antibiotics are costly. So next slide. Yes. Yes, thank you. And then maybe this is the final question we need to raise, empiric antifungal, and I will just bring the surviving sepsis recommendation. So for patients with sepsis and septic shock at high risk of fungal infection, surviving sepsis suggests empiric antifungal therapy or no antifungal therapy. It says weak recommendation, low quality of evidence. So empiric use of antifungal just for in case kind of coverage is not recommended, but like other things we need to consider should be there, like patients at high risk of fungal infection or initial antimicrobials not doing well, or any evidence including culture-based kind of recommendation, like maybe there. So next slide. Yes, this also the repetition of what I have mentioned. Next slide. Maybe. Yes. So on the antifungals, on the antifungal, there are studies, randomized control trial of 260 adults. There is no significant difference in the rate of survivors without any fungal infection at 28 days between micafungin, it's one of the caspofungin group, and placebo treated. So they just evidences doesn't recommend to use empiric antifungal treatments. So finally, this was all the things which I want to raise on this presentation. So coming back to the questions. Next slide, maybe. Yeah. So I think most of the things, questions are answered. So appropriate time, controversial issue, but it's also answered. Maybe if you have questions, you can forward so that we can be in time. Even on these questions, if there is unclear, you can ask me, please.
Yes. Thank you so much, Dr. Nura. That was an amazing lecture, and thank you for your your expertise in that field. We remember the 4Ds. That is really good. I will
Yes.
teach it. Thank you
Yeah.
so much. Anyone has any questions to share? You can just unmute yourself. All right. It's also possible. Dr. Nura, maybe I have one question. Do you use the point of care testing for antimicrobial resistance in your ICU? And point of care testing a lot, or is it something that you would recommend?
So we don't use that one. Honestly, I have to be very honest here. So as much as possible, especially in our ICU, we're trying to like be doing culture. It's culture.
Yes.
As I said, there are different reasons not to use culture, including no bottle available, and then patients not affording, and then no reagents available in our microbiology laboratory. Those are the major concerns. But point of care, I didn't really see practiced anywhere in our institution, not only in our ICU, even in Singapore. I haven't witnessed, but anyone who have experience on that can share us.
Yes.
Yeah.
Anyone with experience on that? Or comment? Okay. No, I think no. Okay. And yeah, and I had a personal question because there's all so I've always learned we give one single shot vancomycin and then we put yeah like a perfusion for a longer time, like a continuum. Do you advise it for meropenem? Because I've seen different papers on it, and some recommend meropenem single shots, and some not. What is your practice on that?
Yeah, the practice was like meropenem for not sepsis, gram-negative sepsis. Is the practice is to give meropenem infusion within 30 to 40 minutes. That's the standard practice we do practice. For example, if it is pancreatitis, need to for necrostomy penetrance and kind of recommendations, we do give 30 to 40 minutes infusion of meropenem. But what we were recommending when we say extended infusion of meropenem is to extend the infusion to like 4 hours, the
Mm-hmm.
same dose, but 4 hour infusion. That is so that most of the time of the day is covered with the infusion. That's one of the, as evidences show, one of the things which enhance the effectiveness of meropenem in gram-negative resistance infections. Yeah.
Okay, so over 4 hours. Okay.
Yeah, and then vancomycin, please, I want to like make it even as a take-home message.
Yes.
Last time, as I said, we have asked our resident, and I think most of them they were not giving. Load vancomycin if you really feel like that it needs to be given. One of the drugs which we feel like it's given irrationally without like MRSA consideration, we're giving anyway vancomycin. But if you like want to dedicate, first make it rational, and then if you really want to dedicate and then give go ahead and give vancomycin, make it a loading dose first. And this loading dose doesn't depend on patient's creatinine, initial creatinine, or a patient have no AKI or not. Like if it is creatinine of 3, 5, 30, it doesn't matter. Loading dose should be given in around 20 to 30 milligram per kg. Thank you.
Okay, that's a
Yeah.
really good take-home message. Thank you.
Yeah.
Any other questions or commentary? Maybe you want to share your experience on your ICUs. Hmm. Okay, so we have a lot of positive feedback from the session, Dr. Nura. Or Dr.
Hello,
Alima, do you have a question?
I've got a question.
Yes, please. Go on.
Thank you for the presentation, Dr. Nora. It was good presentation.
Mhm.
I just wanted to ask on when we suspect that we've got a device like a central venous catheter or
Mhm.
a transurethral catheter. I saw on one of the slides you said we shouldn't take the tip for culture. I wanted more elaboration on that. Should we do that or we shouldn't send the catheter tips for culture, or we just take the blood culture if we think it's a central venous line, or we just send the urine for culture if we think it's the transurethral catheter which is causing infection. Thank you.
Okay. So if I get you right, in one of my slides, it says do not send the catheter tip for culture, right?
Yes, yes, yes.
Yeah, yes. So that's one of the things which makes bias on the antimicrobial growth. So previously we thought that we just, if we like consider, as you said, central venous catheter, and then if we attribute that catheter our source of infection, we do take the catheter per se and then check with if there will be growth from that tip of the culture. And but the recommendations I have seen is that the culture tip is very much susceptible for contamination, and then it's not going to give you the whole profile if the patient has infection because of that, or the bacteria, the bacteria, or it's. I mean, it's not like it's not a representative of the patient's bacteremia that catheter tip grows, and then so they didn't recommend like doing culture from the catheter tip only. Rather, they do a whole representation of blood culture or midstream urine culture for. For the UTI, for catheter-associated UTI, do midstream blood culture for CVC focus, you do a blood culture. But if you even at all want to do a tip culture, you have to combine it with a blood culture, and then so that you see the load of the growth or the colony forming root from the different sides. So it's to say that just culturing the tip of the catheter from urinary or central venous catheter is very much liable for a negative, biased kind of growth, as it's susceptible for contamination. So it's just don't take that one only as an evidence for a cause. Rather, if at all, you have to combine it with blood or urine culture in that case. Thank you. Nice question, though. That was also my consideration.
Thank you, thank you, thank you.
Dr. Nura, I will repeat what you've said, but so that we understand. So you will take, for example, if you think of a catheter-associated infection,
Yes.
you will take a blood culture from this catheter and from another blood culture, right? And then
Yeah.
take out the catheter. Okay.
Yeah, and take out the catheter. And there is a practice of taking out the catheter and doing a culture, the catheter tip. Did you get it?
Yeah, I
So
get
two
it.
blood cultures from the catheter and from peripheral site is what's recommended. But how about doing culture on the tip itself? Did you get it?
I get it.
That's not what's really a room for bias. So what you said should be the appropriate practice for the
Okay,
catheter.
perfect. Thank you.
Yes.
Any other question? Alima, I see you.
Yes, thank you so much. Very interesting and insightful presentation, Dr. Noor. I was just going to talk about what you said about the getting a local antibiogram, right? So that you will be able to know the sensitivity pattern, of your ICU and your patients, and then the ICU as well. Now, my issue is with the microbiology department not working directly with the ICU in such a way that they do not come to like take samples around the ICU to see what we are growing, and then they do not come to review the patients with us. So I mean, when I was when I was still in active service, because now I'm retired. So that has been the practice, and I tried to change that practice before I left. That the microbiologists need to work hand in hand with the intensivists and the ICU, so that they will be able to know what is growing, if there's anything growing, and from there they can know how to tackle this. Like for instance, you mentioned the escalation, if you know the pathogen that you are treating and things like that. So it's so difficult for clinicians, sometimes, to de-escalate. They just leave the patient on that particular antibiotic for so long. So and I think these are issues that are causing the AMR to keep rising in our ICUs. Yes, and we're seeing a lot of the superbugs around, really. Thank you so much.
Yeah, that's a very good point. So even one of our take-home messages from this should be this collaborative work between intensivists, microbiologists, and also infectious disease specialists. So we do have this antibiograms country level, they say, but I don't see it in a real practice coming to it. You see it on some researchers, honestly speaking, even here, but our microbiology laboratory should give us antibiograms if yearly or even more frequent than that, so that we know what's coming every time. So that's a very good take-home message which we need to put in hold. Thank you very much.
Thank
Yeah,
you.
yeah, yes.
Any other question? I have maybe a question for patients which are at risk of MRSA. Of course, you start broader and you start MRSA adapted your antibiotics, but is there testing for every patient coming into your ICU, or how is it? How do you recommend and handle that?
Yes, so we do send two culture bottles for gram negative and gram positives. I would say the MRSA rate is very low, honestly. In fact, I have seen maybe in these 2 years 2 cases of MRSA. That's an honest finding we have seen. Regardless, though, as I said, with all those risk factors, hospitalization, critical illness, very sick patients kind of considerations, in any surgical site consideration, infections of the respiratory focus, which I didn't see in the recommendation, but when patients come very sick, you don't want to exempt any of the things, but in this kind of scenarios, we need to cover the MRSA with vancomycin usually, and Enterococcus, as you know, they have this empiric resistance for meropenem. So vancomycin resistant Enterococcus are nowadays becoming common for those who are using linezolid for patients who do afford. So linezolid for vancomycin resistance Enterococcus, not MRSA really. Those are very rare scenarios. Vancomycin resistant stuff, I have never seen, I have to be honest here. But MRSA, very rarely we see, but we are covering empirically for those very sick patients and risk factors. Yeah.
When they have sepsis, anyway. Yeah.
Yes.
Thank you.
Sure.
That's true.
Yeah.
Thank you so much, Dr. Nura. We have another question from Malet de Salig, and I hope I pronounce it well. If you want to unmute yourself.
Hello, Dr. Nura. Thank you so much. It was very informative. I just have this question for you and for the team. So you've probably mentioned it. I'm not sure. I joined late. But anyways, the usual recommendation for antibiotics is around 5 to 7 days, assuming you have source control. But there is this trend, or there is this culture of practice of extending for 2 weeks or like that in case of catheter-associated bacterial catheter-associated sepsis, like from central lines or dialysis catheters, and also in resistant microbes, like difficult to treat Pseudomonas. In those cases, I think there was a previous recommendation to extend antibiotics for 2 weeks, assuming you have source control. So how do you see this practice? Is it something that we should do to extend those, if you're considering catheter-related sepsis or difficult to treat Pseudomonas, what should be the duration?
Yeah. So that's from what I read. I have to be honest here. Catheter-associated infections, as you know, CLABSI approach, it has complicated and non-complicated. Complicated with infective endocarditis, if you are really focusing on catheter-associated infection, if there is infective endocarditis or any joint infections or bone infections, kind of thing. These are specific scenarios we really need to prolong our antimicrobial use. And from like a pulmonology perspective, like if patient has findings on their lung, like bronchiectatic changes, so there is a penetrance issue, coverage prolonging findings are there. So those may be specific scenarios which we need to prolong our antibiotics for 2 weeks or beyond. Like you said, infective endocarditis, bone infections, or like joint infections, they may even need, or empyema for that matter, they may need even 6 weeks, kind of special kind of indication for prolonging. Those evidences I have brought, like in balanced trial, this is a general kind of antibiotic coverage for general, like this also considers sepsis of chest focus, sepsis of urinary tract or abdomen focus, and lacking these special scenarios you have mentioned. Those are specific exceptions, maybe with sepsis with complications. Otherwise, that's a general scenario, I would say. But more can be said if anyone wants to say. Yes.
Thank you so much.
Yeah.
Thank you. Any commentaries? Okay. We are a bit ahead of time, to be honest. We started a bit later, but I think we give maybe one last chance for a question of someone and then. Okay. Okay. Perfect. Dr. Nura Nasser, we are really pleased to have this presentation with you. We've learned a lot. And we have a lot of positive feedbacks in the chat. So thank you so much for your time and this presentation. This presentation will be also put online on our website. I will let everyone know when it's online. Thank you so much for that too. And there will be some e-certificate for this session. So everyone who has participated will get an e-certificate. To attest that you've been here and you've heard carefully. So thank you so much. And
thank you so much. Thank you all for attending, and also Dr. Helen, thank you so much for a nice moderation. Thank you.
And yes, so we'll see you next time in 2 weeks' time.
Thank you. Bye.
Thank you, Dr. Alima. Bye.